I've had instances where I've been not able to follow the circulating tumor DNA and say, you know what, it's stable, or I can't even find it. And, 2 years down the line, we're telling them, you know what, let's stop treatment and let's just follow you with scans and follow you with circulating tumor DNA. So it's giving them their life back for a little bit, that autonomy, that they don't have to come every month or every 3 weeks for treatment, because they feel secure that we can detect it on the circulating tumor DNA. We'll see it even before we see it on the scan, and it's giving them this reassurance. And it's a really big discussion, like risk versus benefits, and we don't take it lightly. But, if you've been on treatment for 2 years and we can't find anything, or your disease is stable and we know you're going to be compliant with follow-ups, then that is a patient that we would kind of discuss, hey, are you willing to go through with this?
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hi, everyone. Welcome to The Cancering Show. What if we could detect different types of cancer with a simple blood test? I know that sounds futuristic, and I don't mean to promise that we're there yet, but the technology is emerging. It's called cell-free DNA testing, or liquid biopsy, and it's currently being used in cancer centers across the country to monitor patients who already have a diagnosis of cancer. But we want to know how it could change cancer in the future. Today, we have a very special guest with us, my colleague, Dr. Daisy Escobar, a medical oncologist and hematologist at USA Health Mitchell Cancer Institute, who's going to explore how cell-free DNA testing is changing how we're monitoring patients and how it could be used in the future. Dr. Escobar, welcome to the show.
Hi, it's good to be here.
So we are so excited to have you permanently on staff at Mitchell Cancer Institute, but our listeners haven't really had a great introduction to you yet. Tell us a little bit about yourself.
So I've been in Mobile since about 2016. Originally moved here because my husband matched in residency, and then I started working in clinical trials, matched into internal medicine, and then completed my residency, and then matched into fellowship, did another 3 years here, and then finally decided to stay because it was a good place for just me, my husband, and my son, who's now 12. So, yeah.
That is awesome. I don't think I knew that you had a 12-year-old son. My oldest is 12 this year. Oh, my gosh. She's showing me a baseball picture, folks. So adorable.
Yeah, so that was my life this year, just travel ball, rec ball, all of the balls.
It is a lot. And I hate to say it, our girls, we're like, do you really need to play travel? Because rec feels good enough. And then my youngest thinks that she wants to be a scholarship athlete. And we're like, sweetheart, you don't play any travel ball. So it goes both ways.
Yes, it does.
So we are going to be talking today about what I think is one of the newest things in cancer diagnosis and maybe surveillance more so than diagnosis, cell-free DNA, or what people refer to as liquid biopsy.
Right. So it is called liquid biopsy because it is a blood draw. That's the most beneficial thing about it. You don't have to have a tissue biopsy. You can draw it at any time. Usually, we kind of follow these every 3 months. And like you said, we haven't really been using it in the initial diagnosis and the early stage detection. We more use it on the surveillance side for treatment monitoring and for relapse and recurrence.
Now, my first introduction to cell-free DNA technology was actually when I was pregnant with my babies. So 10 years ago now, 12 years ago, when I was offered this, I was one of the first people at USA to be offered this as a test for Down syndrome while I was pregnant. So you no longer had to biopsy the placenta to get that test result, but could do it with a blood test. Can you explain to our listeners kind of how it can be both of those things?
Well, when you talk about cell-free DNA, you're talking about this could be in normal cells, and it's just generated from the cells dying. When you look at it in cancer cells, it's actually called circulating tumor DNA, and it's found in a lesser amount, but you're able to trace it. And that makes it harder when you're looking at early detection because you don't have such a high amount. You see it more when you have metastatic disease. But cell-free can encompass benign and malignant disease in it. And you can see it in the blood, the plasma, all the umbilical cord, and pretty much anything except when you're looking and through it crossing like the CNS barrier, but you can see it in CSF.
And so I think the biggest point of this technology is that it has to be different from our normal cells. So, in pregnancy, the fetal tissue is different. And obviously, if there was a Down syndrome chromosome, that would be different. For tumor cells, how do they know that it's different from that person's normal cells?
So that's actually really interesting, because the way that we're using it right now is you actually have to have just a previous biopsy. They draw the blood and then they compare the sample and the DNA to that previous tissue biopsy. And we've run into some issues with that when someone has had a biopsy like 2 or 3 years prior, because then that tissue has become too old. But if you have a fresher biopsy, they compare what they extract from the tissue and then they extract it from the blood. And then after that, you really just need that blood biopsy, like we like to call it, but it's just that blood draw.
That's incredible. And we know our cancer patients are getting labs otherwise for other reasons, so it's super easy to do.
Right. And then sometimes even if they're not coming in, depending on what company you use, they actually can send people to have these blood biopsies done at home, which makes it so much easier if they're not able to come in for a visit.
Now, how frequently do you do this? And does it take the place of other surveillance, like a physical exam or a CAT scan?
So depending on what you're using it for. So if you're using it for surveillance, then it's every 3 months. If you're using it as like a neoadjuvant approach before surgery, you would kind of draw one before surgery, you do one about 6 weeks after surgery, and then you continue to monitor every 3 to 6 months. And you're looking to see how much circulating tumor DNA is in there. And it's really interesting because sometimes you can actually see a spike in the circulating tumor DNA before you even see it on a scan on tumor markers themselves. And then you're kind of left in this precarious position, like, what do? We can't see it on a scan. We don't see it on the tumor markers. Like, you're just telling this patient, like, hey, we know your cancer is growing, but at this point we can't identify where it is. So we have to watch and wait. And yes, you'll scan sooner and then you'll catch it sooner.
Okay. And I would suspect, because I know the data in ovarian cancer, we know that if your tumor marker is rising, but your scan is still negative, there's actually no additional benefit to treating sooner because it doesn't impact survival. Do we know that for other cancers? Do we know when is the right time to treat?
Yeah, so that's the same thing, kind of what I was saying. It becomes hard when you have a colorectal and you're following this circulating or cell-free DNA and it's rising and you can't see it on the scan. That's always what we discuss at our multidisciplinary tumor boards, because we're trying to see, do we treat? But then it's like, what are we treating? Is it something that could pop up and you could potentially resect and then just do some radiation? Or is it going to be full-blown metastatic disease? Like, it's this watchful waiting that is harder on the patient more than anybody, because they know these numbers are going up. They're multiplying and they're like, well, why don't you treat me? And it's like, we can't, because we might waste a resource that we could potentially use farther in the future.
So are oncologists using this all the time now, or is it only for some patients?
So it kind of depends. So we use it for colorectal, we use it for breast, we use it for lung, for muscle invasive bladder cancer. We use it for patients that have been treated with immunotherapy. But there's issues with that too. Like, I had a patient that had stage 4 GE junction cancer. She had a transplant, a bone marrow transplant. I tried to get circulating tumor DNA on her, and then they said they couldn't because she had this transplant. So there's issues with that. And then again, like I said, if you were diagnosed 3 years prior and you don't have any other tissue, you may not even be able to extract that DNA from the tissue, where they will not be able to do that blood biopsy on it. And, they're trying to get around that and trying to develop more resources now so that they can do it. But at this point, that is a limitation.
Okay. But something that a new biopsy could overcome.
Yes. If they develop a new lesion, we're not just going to biopsy.
Yes, of course.
to biopsy.
Of course. If there was cancer on a scan that was biopsyable.
Yes, then we could run it from there. Mm-hmm. And then they're actually able to detect, when I spoke with them, that multiple different primaries, which is also nice.
Yeah. And our listeners know that I'm a GYN oncologist, and you didn't mention GYN cancers on that list. And I would say that that is true, that it has not become the standard of care in my specialty. There are not the trials to suggest that it impacts survival. And really, we also kind of, I think, are less aggressive in scans than other cancer types because we have the data that says that it doesn't make a difference. Now, is there data to support using these tests to improve survival in all these cancers, or do you think that the technology is outpacing the science?
I think if you're metastatic, there is data to support that you need to start the circulating tumor DNA and kind of follow it every 3 months. And in a way, it kind of helps. Like if you have a metastatic patient, you're kind of telling them, well, you're going to be on this treatment until you're no longer responding to it or you can't tolerate it. But I've had instances where I've been not able to follow the circulating tumor DNA and say, you know what, it's stable or I can't even find it. And, 2 years down the line, we're telling them, you know what, let's stop treatment and let's just follow you with scans and follow you with circulating tumor DNA. So it's giving them their life back for a little bit, that autonomy that they don't have to come every month or every 3 weeks, for treatment because they feel secure that we can detect it on the circulating tumor DNA. We'll see it even before we see it on the scan, and it's giving them this reassurance. And we're able to minimize the toxicities that they're having. Is this the case for all patients? Not necessarily. And, it really is case by case on the patients. And it's a really big discussion like risk versus benefits. And we don't take it lightly. But, if you've been on treatment for 2 years and we can't find anything or your disease is stable and we know you're going to be compliant with follow-ups, then that is a patient that we would kind of discuss, hey, are you willing to go through with this?
Right. And since it is just a blood trial, the risk really is that emotional trauma, right? I mean, seriously, that you take a patient and, I think about it this way. Imagine that we knew for a fact that it would be a year before they had visible disease on a scan. But now you've taken their remission and shortened it to 6 months because at 6 months, this test starts rising. Right. So it's been 6 months feeling cancer-free and then another 6 months in kind of watchful worrying. More than watchful waiting,
right?
As opposed to a year of thinking that they're cancer-free. So there definitely are pros and cons, it sounds like.
Right. And, that's always the risk because then they're going to start worrying like, oh, my number went up by like 1 point. What does that mean? And at that point, we really have to kind of reassure them and say, hey, we'll continue watching it every 3 months. We can scan, but we're not going to scan sooner unless, like we tell them, you start having issues, then we'll scan sooner. Mm-hmm. But like you said, it is watchful worrying once those numbers start going up. Yeah. But I mean, I've seen it where I thought they were metastatic and we started treatment on them and I didn't think they were going to respond. And I think their circulating tumor DNA was like 180. I repeated it and it was 0. And I said, this is not right. No. And we got a PET scan and absolutely no evidence of disease. And now they've had 2 more circulating tumor DNAs and 2 more PET scans and no evidence of disease. But with him, I've been hesitant to stop treatment because he recurred so quickly. So I said, let's make sure this is stable for at least 6 months to a year. And then, we'll revisit that conversation. Yeah.
Amazing. And is this technology affordable? Do you feel like every patient has access to it, or are there access issues?
So it depends on your insurance, what they'll be willing to approve. But I haven't really had any issues. And I know the companies that we've worked with have some charity assistance if this was needed. So I think it should be affordable and easily accessible to everybody. If they fall within the guidelines they would respond to it.
Okay. Excellent. And so going forward, how do you see this technology either changing or improving or kind of being that cancer game changer that we've been looking for?
So I know the big thing that they're looking at right now is more in early detection because when you look at the screening guidelines, you have a low-dose CT for lung cancer, you have cervical cancer screening with the HPV and the pap smear for cervical cancer, you have mammograms for breast cancer, but you look at ovarian cancer, you look at CNS cancers, there's pancreatic cancer. There is no screening preventatively that you could do. And they're starting to look at that in that field because by the time you detect some of these cancers, they are stage 4 metastatic. And it makes it harder to treat them because their prognosis has decreased
Right. And, right now we're taking the old biopsy and looking for your particular tumor's DNA signature in your particular bloodstream. But are they starting to take all of this into some sort of, big giant database and determine what is a colon cancer signature or a cervical cancer signature, so that people don't have to have pap smears or don't have to have colonoscopies? They could just have a blood test for all their cancer screenings.
So it's actually reading up on that, and they are looking at that, there are some clinical trials that they're looking at doing just the screenings, but they're comparing them to the standard of care. But with the circulating free DNA, the exomes that they have, they're so small that they're finding it difficult to just be able to rely on that as a screening tool only. So they are actually using both like scans or like low-dose CT scan or, a pap smear or a mammogram to be in conjunction with that, because they still haven't been able to fully isolate that as your own screening tool.
Got it. So for now, everybody out there, you heard it here first. Keep doing your screenings just like you normally would.
Correct.
And of course, we would tell all of you who are cancering to keep doing your surveillance visits just like you should. But it sounds like, regardless of your cancer type, it's time to have a conversation with your doctor about cancer tumor DNA.
Right. See if that's an option for you, or if it's something maybe that you could think about in the future if you were to reoccur. Hopefully you don't, but that's always the worry. And then you can start screening with that.
Okay. Well, I'm going to have to read up more about the latest data in GYN cancers, because now I've just invited every patient of mine who's listening to come and ask me about it. So I'll be ready next week. So Dr. Escobar, anything else you would add to our conversation that I haven't asked you?
With anything, you have to be cautious, because if you find your tumor markers are rising and you can't find cancer, you can't go through this like black hole trying to search. And if they can't find cancer, it may just be a false positive, even though it's rarely possible. But just keep in mind that sometimes you may not find anything and you will have to wait. And that's going to be the hardest part.
I know. It is the hardest part for every patient who is waiting on a diagnosis after an abnormal scan and things like that. And we certainly see that for our recurrent patients as well.
Yes.
We talk about this a lot in survivorship, the waiting. And we don't have a patient sitting here with us, and I'm really curious to get their perspective. So please, if you want to write in or make comments on the show, we would love them. But I would say that I think cancer patients always feel like they're waiting.
Well, they're always waiting for the next scan, the next visit. It's always like, is it coming back? There's always that. I don't know if you've had this, but I've had it where, you have the port and you're like, okay, well, it's been a year, it's a year and a half, 2 years, you want to think about taking out that port. And some patients don't want to because they feel like if they take it out, their cancer is going to come back.
Yes,
and it's
the Murphy's Law.
Yeah, and it's always providing that reassurance. I mean, I have a breast cancer patient that I'm doing the circulating tumor DNA. I'm doing the breast cancer markers, and they're negative. And I'm telling her, hey, you should be on surveillance every 6 months. And she's still wanting to come every 3 months. And it's more for her reassurance that if she keeps on the schedule, that it's less likely for her cancer to come back. And it's always just like, it's providing that reassurance and like, hey, no. And I tell her, I'm going to do whatever you want. If you want to see me every 3 months, I'm okay with that. You're the one that's driving to see me. I'm here anyways, but more providing reassurance. But like sometimes if the numbers do go up, also providing that reassurance that we are going to do the best that we can. But if we can't find this cancer, then we have to really wait until we can detect it.
Mm-hmm. And just for all the reasons that you said, there's so many different treatment options available depending on where it actually is and how many different spots they are and where each of those are located, if they're in 3 different parts of the body or if it's all located in one area.
And then sometimes, treatment is always changing. They're always coming out with new guidelines and new recommendations. And maybe that waiting will allow us to give them a little bit more targeted treatment, because that's where we're going also, just targeting the treatment and giving them a better response. I mean, metastatic patients are living so much longer. I have so many that are classified as metastatic, and, we're stopping treatment on them because we've, in all intents and purposes, cured them.
That's amazing. Yeah, I think there's so many things to be hopeful for, even in metastatic disease. I would just say, and I'll ask you your best advice as well, but I get this a couple of times a year where I have a patient whose CA-125 is rising, or for us, that's the GYN cancer marker, mainly ovarian cancer marker, and the scan is negative. And what happens next? What do they do? What do they do during the next 3 months? And I always say kind of, not that you need to do anything particularly special, but kind of preparing for that fight a little bit, working on your nutrition, walking and exercising, kind of also doing that trip or that thing that maybe you have been putting off. Now is a good time to go ahead and do those things, because at the next scan in 3 months, we might be talking about cancer treatment. So it's almost, it doesn't have to be a time of fear. It can be a time of preparation.
Right. And you just kind of getting them ready, like thinking, okay, if treatment is coming up, planning for that, but also having them reassess, like, what kind of quality of life do they want? Because that's the one thing I ask them, like, at the end of the day, what is it that you really want to do? I had one person that told me, I just want to be able to garden. And then when she told me I can't garden, we had that discussion like, okay, you said this was your goal. I wanted to be able to garden. You can't do that anymore. She's like, yeah, I can't. I'm like, what do you want to do now? And at that point, she decided that she didn't want to do treatment, because it's really assessing what you want for yourself as a person. Because there may come a time where your family members may have to start making decisions for you. But if you can make what your wants clear, then that keeps your autonomy and yourself as a person present in everything that you do. And it doesn't feel like your family is making these decisions for you. And they feel more comfortable as time progresses and as things happen.
Yeah, I agree. I think that's another great point. And we talk about this a lot on the show as well, but that can be another great point of preparation and as should be true for any of us, right? That your family is aware of your wishes and that you have a good idea of what you want in terms of quality of life and for the next weeks, months, years, and even further down the road, because we know so many patients with recurrent disease live for a very long time.
Right.
So thank you so much for coming in the studio, Daisy. I so enjoyed our conversation, and I learned a ton, and I know our listeners did too.
Awesome. That's really good to hear.
What a great episode, y'all. I have been wanting to bring you this episode for months now, exploring cell-free DNA testing with Dr. Daisy Escobar. We learned about this emerging technology that currently allows oncologists to monitor cancer through a simple blood draw instead of needing scans every time you go visit. But this current application in cancer surveillance could lead to a potential future role in early detection. To all of our listeners, I encourage you to discuss the possibility with your oncologist of whether this new kind of monitoring is right for you. Until next time, keep cancering and take care of yourself. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.